ملهاش حركة خالص.
ده next back وده البوينتر الأحمر أول واحد.
اوكي. أنا بحب الأونلاين بوينتر، أحاول أجيبه أنا.
ممكن كيبورد وممكن
في الأونلاين بوينتر اللي هو بيجي ده مش موجود.
لا يعني هو ده الهاشتاج.
alright.
ده next ده البوينتر الأحمر وده عشان نجيب السلايد الجاية وده السلايد اللي
Excellent. شكرا. Thank you, dear professors and colleagues, for inviting me to present this. I think it's a difficult topic, a little bit. It's not for the basic electrophysiologist. It's about 3D mapping in cases with supraventricular tachycardias. So the previous lecture showed us that, and I quote what was said, that SVT ablation is a safe and effective with very low recurrence rates. But my presentation will show you some of the more difficult cases in which recurrences may be a little bit more. So I'll dig in immediately into the presentation with the first case. And this first case is a flutter case. It's not my own case, but I had a similar case maybe 8 to 10 years ago. And I was surprised by this case, and I couldn't actually elucidate the mechanism of the flutter. And then maybe after 10 years, I came across this pattern. So this is a case of typical atrial flutter, typical counterclockwise atrial flutter, in which we did actually a CTI ablation. And after the CTI ablation, you can see استخدم الماوس أحسن I think. Okay, so استخدم الماوس أحسن ماشي. So this case, so after we did the flutter line, that flutter didn't terminate and it kept going on in the counterclockwise direction. So we cardioverted the patient to elucidate the mechanism of the flutter. So at baseline, you can see the chevron shape on the halo catheter denoting conduction across the cavotricuspid isthmus. However, after ablation, you can see what is called the sigmoid pattern. I had this pattern in 2 patients before, what is called a sigmoid pattern. And we thought that maybe the tachycardia became another type of tachycardia. What happens here is that during CS proximal pacing, instead of the impulse going through the endocardial layer and activating in a chevron shape, what happens is that there is a deep epicardial muscle bundle through which the propagation occurs, and then it breaks out from the epicardium to the endocardium, distal and lateral to the conduction line of block that we have created. And then it propagates in a focal manner, what seems to be a focal manner, orthodromically and then antidromically, and continue the cycle, thus creating that sigmoid pattern. Such cases are very difficult to know, and they are very difficult to treat by re-ablating on top of the same line. And we have to see where the breakthrough laterally is as a focal point through 3D mapping, and then we ablate on top of this breakthrough point. And at that point, you can acquire the usual, actually, pattern of conduction block across the isthmus. So in my case, actually, I didn't recognize this phenomena at that time, maybe 8 to 10 years ago, but I tell you, it is not that infrequent. Maybe you yourselves have seen such a case before. So this is a more recent publication on the same concept of an epicardial endocardial breakthrough in a patient with multiple failures of intractable common atrial flutter. Such cases you can see here. This is the flutter circuit. You have already done multiple lines of ablation without termination. The wavefront comes to the lateral border of the scar you created, and then it digs deep epicardially, and then with a focal outbreak near the coronary sinus ostium, and then it propagates in a more or less focal manner, antidromically as well as orthodromically. And you can see here that immediately after the line of block, you have a more distant electrogram as opposed to more actually medially at the breakthrough site. And it perplexes us, such a phenomena, and we can think that this is another tachycardia, a focal atrial tachycardia, but actually it is the same flutter with an epicardial to endocardial breakthrough. You can even entrain the tachycardia with perfect cycle lengths, post-pacing intervals from this focal breakthrough site, confirming that it's actually not a focal tachycardia, but a reentrant, the same reentrant tachycardia. So the same thing. Okay. Even in this case, this was published by Pierre Jailly and Michel Hasseguer group, showing counterclockwise atrial flutter, even though you have double potentials of block across the CTI. And again, confirming that actually this was very intriguing in the terms that the impulse propagates from endocardial to epicardial and then to the coronary sinus musculature, and then it outbreaks and complete the circuit. And this case was actually in the literature ablated inside a diverticulum inside the coronary sinus. So just by a focal ablation at this breakthrough site, which was identified again by high density mapping, immediate termination of the flutter, which couldn't have been done without this focal ablation inside the coronary sinus. And he described a right atrial coronary sinus epicardial connection. Okay, this is what you see with the focal breakthrough and epi-endo communication at the os of the coronary sinus. So another type of tachycardia, this tachycardia. So this patient has a normal sinus rhythm, but she develops frequent AVRTs utilizing what seems to be a lateral accessory pathway. But this patient had undergone multiple ablations, so 2 or 3 ablations in the past, with always failure and recurrence. And for such cases, 3D high density mapping is very useful, using the open window of interest to delineate that there is actually not a focal or a narrow pre-excitation, but rather a very wide sheet of pre-excitation, and you had to actually draw a line of block across the mitral isthmus in order to get rid of this tachycardia, which happened after 6 seconds from completing this line. So here delineating the importance of 3D mapping. And the open window of interest is very important in such cases, because actually you delineate the electrograms of interest with the deepest dV over dt on the unipolar recording, so as to pinpoint where the communication between the atrium and the ventricle is. And this is the actual propagation map. You can see that it is not just a focal breakthrough, but it is a rather wide sheet of accessory pathway. Okay. It's not working. I don't know why.
The next to the back,
Okay. So, next case is a patient with more or less a subtle pre-excitation. You can see a shortish PR interval, not very much of a delta wave, but this case has Epstein anomaly. And it presented with this wide QRS tachycardia. And whenever you have a more or less subtle pre-excitation in an Epstein patient with a left bundle branch block pattern of wide complex tachycardia, our minds automatically go to a Mayheim atriofascicular tachycardia. So it was indeed a Mayheim tachycardia, but we couldn't find a Mayheim potential at the annulus. And such cases, you can ablate the insertion of the Mayheim fiber apically, like here. But you cannot do this without the utilization of a high-density mapping system with the HD grid, for example, as in this case. And indeed, you can see here the Mayheim potential distally inside the right ventricular apex. And ablation at that point eliminated the Mayheim fiber. Fifth case, again, this is a parahesian accessory pathway, very dangerous position in which ablation can actually go to a complete heart block. This patient was ablated 3 times before, conventionally, but always with the recurrence of the tachycardia and the pre-excitation. And here, high-density mapping is very important. Why? To delineate where the His bundle is, the AV node is, and then see where it is safe actually to ablate. And because this patient was ablated from the right atrial side multiple times, so they opted to go to the left coronary cusp, yes, the non-coronary cusp, right? Okay. Yeah, and then deliver ablation lesions here, guided also by the electroanatomical map, with actually restoration of normal conduction, but with the right bundle branch block, which can occur because of the multiple failed ablations before. So they ablated the right bundle in the previous sessions, but fortunately enough, no severe conduction defect. I think I'll just skip to the consensus, the summary of this presentation. So in 2019, the HRS, together with the Asia Pacific HRS, concluded that it's a class 1 indication to use 3D mapping in SVTs in, for example, pregnant patients, pediatric patients, and also with midline accessory pathways like mid-septal and anteroseptal pathways. And also it should be a consideration, also a class 2A consideration, to apply to apply also 3D mapping in patients who are deemed having high failure rates, like, for example, right-sided accessory pathways, unstable catheter position, or difficult positions to actually to ablate. And I thank you very much for your attention. Thank you.